Hello everybody, this is Dr. Nadeem and we are with Neelam Pack Lectures, the PALM series, which is practical aspect of lab medicine. As you are aware, all our lectures are available on YouTube. We have a Telegram group. You can join this group. This is very helpful to access all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key by which you can navigate between the Google Drive and the PDF. The aim of this platform is to encourage national and international experts to come forward and share their knowledge and participate in the improvement of standard of understanding of pathology for the benefit of students. We invite all interested experts who want to take lectures on this platform to come forward. They can write to us and we will definitely give them an opportunity to take lectures on this platform. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And this is PALM-07, which we are streaming live from RG Kaur Medical College, Kolkata. The topic of the day is Pathophysiology of Jaundice, and to talk on that, we have Dr. SANTASMITA, who is an MBBS, MD Biochemistry, Associate Professor in the Department of Biochemistry, RG Kaur Medical College Hospital, member of the Curriculum Subcommittee at RG Kaur Medical College, Empanelled as Technical Assessor for NABL, Consultant Biochemist at NG Medicare, serving as a guide and co-guide for MD Biochemistry and other discipline students, published various articles in national and international index journals. With this, I would request Dr. SANTASMITA to start her talk on Pathophysiology of Jaundice. Over to you.
Thank you, Dr. Nadeem, for such nice introduction, and thanks to you for giving me an opportunity to become a part of your endeavor. Today, I will be presenting on pathophysiology of jaundice. So the session objectives are, at the end of this session, the audience will be able to define jaundice and explain the biochemical basis of jaundice. The classification of different types of jaundice will be provided, and they will be able to describe the pathophysiology of every type of jaundice. And with all this information, they will be able to differentiate between various types of jaundice by laboratory investigation. So jaundice can be defined by hyperbilirubinemia and deposition of bile pigment in the skin, mucous membranes and sclera with a resulting yellow appearance of the patient. So this jaundice can occur either due to overproduction of bilirubin or it can occur due to under excretion of bilirubin. So to understand the pathophysiology of jaundice, it is important first to become familiar with the major aspects of bilirubin formation and metabolism. So bilirubin is produced from catabolism of heme. So 85% of bilirubin is derived from breakdown of senescent red cells, and the remaining 15% is derived from turnover of hepatic heme or various hemoproteins and from premature destruction of red cell precursors in the bone marrow. So once the senescent RBCs are being destroyed, the hemoglobin comes out of the cells and the heme and the globin moiety, they are being separated. The globin is being further broken down into the constituent amino acids, and these amino acids are again incorporated into the amino acid pool. The heme will be next acted upon by the enzyme heme oxygenase, which we will describe in our next slide, and the iron will be recycled. In the microsomal tissues, heme will be acted upon by the enzyme heme oxygenase, which is a flavoprotein dependent enzyme, and it requires NADPH along with it. By action of this enzyme, heme is converted to biliverdin. Now biliverdin will be again acted upon by the enzyme biliverdin reductase, which will again require the coenzyme NADPH. And at the end product of this reaction is formation of bilirubin. Now this bilirubin, which is being formed, it is essentially called as the unconjugated bilirubin. And the bilirubin that is formed in the reticuloendothelial cells of the spleen, they will be eventually released in the blood circulation, but the inherent property, that is they are being non-polar and they are sparingly water soluble in nature, so they will require a transport for circulation in the blood. So the transporter here is albumin, which is a polar moiety, and it helps in transporting this non-polar bilirubin. So with help of albumin, the bilirubin after synthesis in the reticular endothelial cells will reach the hepatocyte. Now albumin bound bilirubin will passes through the sinusoidal blood into the endothelial cell fenestra. So here, after coming into the hepatocyte surface, the uptake of bilirubin will happen, and this hepatocellular uptake will occur by facilitated diffusion or by simple diffusional process. Once it gets inside the cell, it will be bound with one of the protein that is called glutathione S transferase, which helps to sequester bilirubin inside the hepatocytes. Once it is placed inside the hepatocyte, next it will be subjected to conjugation. For conjugation, an enzyme is there that is called bilirubin UDP glucuronosyl transferase. This UGT1 will act on unconjugated bilirubin and it will convert it to conjugated bilirubin. In the first step, it is converted to bilirubin monoglucuronide. Then it will be again acted upon by the enzyme bilirubin UDP glucuronosyl transferase and it is converted to bilirubin diglucuronides. Both of these bilirubin monoglucuronides and diglucuronides, they will be actively transported across the canalicular membrane into the bile with help of a transporter that is called MRP2 or multi-drug resistant protein 2. In addition to the direct excretion of bilirubin glucuronides, a portion are transported into the portal circulation by MRP3 and subjected to reuptake into the hepatocyte by organic anion transporter 1 and 3. So the UDP glucuronosyl transferase, the enzyme which has been already mentioned, so it is converting bilirubin to bilirubin monoglucuronide and bilirubin diglucuronide. And among them, 80% of the molecules will be in the bilirubin diglucuronide form, while 20% are in the monoglucuronides form. There are certain drugs like primaquine, novobiocin, and chloramphenicol. They can interfere with this conjugation process and may cause jaundice. Now, extrahepatic aspects of bilirubin disposition. So, following secretion into bile, conjugated bilirubin reaches duodenum and it passes down the gastrointestinal tract without reabsorption by the intestinal mucosa. Some of the fraction is being converted by bacterial metabolism in the gut to water-soluble colorless compound urobilinogen. Urobilinogen can undergo enterohepatic circulation. Urobilinogen not taken up by the liver reaches the systemic circulation from which some is cleared by the kidneys. Unconjugated bilirubin is usually not excreted in the urine as it is extremely tightly bound to albumin. So there is no tubular mechanism for its renal secretion. In contrast, the bilirubin conjugates, they can be readily filtered at the glomerulus and can appear in the urine in various disorders. So now with all this information regarding the bilirubin synthesis and the bilirubin transport and metabolism, now we will focus in the different types of bilirubin. So here we have already mentioned regarding two types of bilirubin. One is the conjugated bilirubin and another is the unconjugated bilirubin. So this conjugated bilirubin can be also termed as the direct bilirubin because it is specifically the direct fraction which reacts with the diazotide acid in the absence of an accelerator substance such as alcohol. This is the basis of this Vandenberg reaction from where it was originally being estimated. So the other fraction is mentioned as the indirect fraction or the unconjugated bilirubin. And both of these fraction in together, they will constitute the total bilirubin. So the normal serum bilirubin level ranges from 0.2 to 0.8 milligram per deciliter, among which the unconjugated fraction is 0.2 to 0.6. And while the conjugated bilirubin is only 0 to 0.2 milligram per deciliter. If the serum bilirubin level exceeds 1 milligram per dl, the condition is called as hyperbilirubinemia. Once the level is between 1 and 2 milligram per dl, this is indicative of latent jaundice. And once it reaches around above the 3 milligram per dl, then we can see the particular discoloration. Now, certain properties of unconjugated and properties of conjugated bilirubin must be discussed before we will actually proceed towards various diseases. So, unconjugated bilirubin is virtually insoluble in water at physiologic pH. And we have already seen that they can exist in tight complexes with serum albumin. As a result, they cannot be excreted in the urine even when blood levels are extremely high. So what we can do the effect? So this fraction of bilirubin may diffuse into tissues, particularly the brain in infants, and this can produce toxic injury. And this condition we can observe in hemolytic disease of the newborn, which we can see that this unconjugated bilirubin gets accumulated in the brain and it causes severe neurologic damage, and which is referred to as kernicterus. Now, conjugated bilirubin is different in property in comparison to unconjugated bilirubin. So, as there is conjugation with help of this UDP glucuronosyl transferase enzyme we have seen, so it becomes somewhat water soluble. So, the non-polar nature of unconjugated bilirubin that was present. So, with help of conjugation, we are obtaining a water soluble non-toxic compound which is only loosely bound to albumin. And due to its solubility and weak association with albumin, excess conjugated bilirubin in plasma can be easily excreted in urine. And one of an important fraction of this conjugated bilirubin, that is also known as delta bilirubin, it is a species which is covalently bound to albumin. And this discovery of this delta bilirubin has solved the mystery of persistent high bilirubin concentration that mostly present in the patient who are suffering from intrahepatic or obstructive jaundice for long duration, because the delta bilirubin fraction, as it is covalently bound to albumin, so the clearance of this fraction is along with the half-life of the albumin, that is approximately 17 to 19 days. So the clearance of delta bilirubin is being delayed. So even the jaundice is getting cured or the enzyme level will be decreased, but still the bilirubin fraction can be higher. So that is being contributed by the fraction of this delta bilirubin. Next, we will discuss about the various types of jaundice. So jaundice can be classified into three categories. That is, one is the prehepatic, hepatic, and post-hepatic. So the prehepatic, so as we have seen that this bilirubin is being mostly synthesized from the destruction of the senescent RBCs. So the prehepatic means where there is excess production of bilirubin due to certain hemolytic conditions. Next, once it reaches the liver, we have seen that inside the liver, after uptake, it undergoes certain conjugation or intracellular binding, and then it is secreted. So the various liver diseases can affect bilirubin metabolism. So the second category is hepatic jaundice. And the third one is the post-hepatic jaundice, where the excretion of bilirubin from liver to the biliary system and pancreas, that can be affected. So accordingly, these three types of jaundice are there. Now, for our convenience, we can describe jaundice under the category of unconjugated and conjugated hyperbilirubinemia. So the conjugated, unconjugated hyperbilirubinemia will be discussed, and the second category is the conjugated hyperbilirubinemia, which can be either predominant conjugated hyperbilirubinemia or it can be a mixed variety. So the disorder of bilirubin metabolism, which is leading to unconjugated hyperbilirubinemia, it can be caused either due to two mechanisms. So first one is the increased bilirubin production. So increased bilirubin production, as we have already seen, that the increased destruction of the RBCs, that is various hemolytic anemias, they can cause increased bilirubin production. So this hemolytic anemia can be there can be various causes, like glucose 6-phosphate dehydrogenase deficiency is one of the reasons. Then except that there are pyruvate kinase deficiency, there are other diseases like hereditary spherocytosis, hereditary elliptocytosis, ovalocytosis, or various myeloproliferative neoplasm. They can ultimately give rise to hemolytic anemias. Then ineffective erythropoiesis in various conditions like pernicious anemia or thalassemia, they can cause increased bilirubin production. And the third cause of increased bilirubin production, which is leading to unconjugated hyperbilirubinemia, is the degradation of the hemoglobin that is present in the extravascular collection of erythrocytes like a large hematoma. So from there we can see that increased bilirubin production can happen. So what happens in this hemolytic or prehepatic jaundice? So we can see that as there is increased hemolysis, so the excessive production of this unconjugated bilirubin will happen, and this unconjugated bilirubin, as it is produced in excessive quantity, so it exceeds the capability of conjugation of liver. So as a result of that, we will see that unconjugated bilirubin concentration will become much higher in the blood. So for investigating various causes of hemolytic jaundice, we can either go for estimation of blood. So there we will clearly see that the total bilirubin fraction is increased. Among it, the indirect bilirubin fraction will be increased more, and the direct bilirubin can be normal. If we do the Ehrlich's test for the urine urobilinogen, it will be positive. Hayes sulfur test for bile salt or the Foch's test for bilirubin, it will be essentially negative. And if there are certain myeloproliferative disorder, we can see the hyperplasia of bone marrow. In case of this hemolytic anemia, reticulocytosis can be present in peripheral blood. Now, prehepatic jaundice can be caused by other mechanisms like decreased hepatic bilirubin clearance. So here, decreased hepatic uptake can occur either in a congenital disorder that is called the Gilbert syndrome, or due to defective conjugation. This defective conjugation, there are various disorders. One of the congenital disorder is this Crigler-Najjar syndrome, and another entity is there that is called physiologic neonatal jaundice. So neonatal physiologic jaundice is where the bilirubin UTP glucuronosyl transferase activity is reduced. So here, due to the prematurity or the impaired maturation of the enzyme system, the activity of this conjugating enzyme is reduced. Now, various alternative excretory pathways are there which allow passage of unconjugated bilirubin into the gut. Since the intestinal flora that convert bilirubin to urobilinogen are also underdeveloped, the enterohepatic circulation of this unconjugated bilirubin will start. And as a result of that, the unconjugated bilirubin fraction will be increased in the blood of the neonate. So there we can see that there is a possibility of mild unconjugated hyperbilirubinemia between day 2nd and the 5th after birth. So here, as being a physiological condition, so the peak levels typically reaches up to 5 to 10 milligram per deciliter, and they will decline to normal adult concentration within 2 weeks. Now, principal differential characteristics of the congenital disorders which are giving rise to unconjugated hyperbilirubinemia. So we have seen three categories. One is the Crigler-Najjar syndrome type 1, type 2, and the Gilbert syndrome. So in the first category, we can see that in the Crigler-Najjar syndrome type 1, the enzyme bilirubin UDP glucuronosyl transferase activity is typically absent, or it can be very less in actual activity in certain patients. In type 2 Crigler-Najjar syndrome, the activity of this enzyme is markedly reduced, that is around 0 to 10% of the normal. And in Gilbert syndrome, there is also reduced activity, that is around 10 to 33% of normal. So as a result of that, in case of Crigler-Najjar syndrome type 1, we can see that the bilirubin, unconjugated bilirubin level will be much higher, and the total bilirubin fraction can go up to 18 to 45 milligram per deciliter. In case of type 2 Crigler-Najjar syndrome, the level is slightly lower, that is around 6 to 25 milligram per deciliter. And in case of Gilbert syndrome, it is typically less than equal to 4 milligram per dl. The routine liver test, that are the other liver enzymes, if we do here, so in all of these three cases, the liver enzymes will be normal. And as in case of type 1 Crigler-Najjar syndrome, we can see that the bilirubin level is much higher, and we have already seen that the unconjugated bilirubin fraction, when it goes up, it can cross the blood-brain barrier. So the probability of kernicterus is higher in case of Crigler-Najjar syndrome type 1. But in case of Crigler-Najjar syndrome type 2, as the bilirubin level is not much higher, so here the possibility of kernicterus is rare, and in Gilbert syndrome there is no such possibility. The hepatic histology is essentially normal in type 1 and type 2 Crigler-Najjar syndrome. In case of Gilbert syndrome, it is usually normal, but in certain conditions there can be increased lipofuscin pigment in some conditions. The bile characteristics, in case of type 1 Crigler-Najjar syndrome, it will be pale or colorless. In case of type 2, it can be pigmented, and in Gilbert syndrome, it will be normal dark color. And the bilirubin fraction, we have already seen that the 90% of the unconjugated bilirubin will be present in type 1, because here the enzyme activity is grossly deficient. In the type 2 variety, the largest fraction will be monoconjugates. And in the Gilbert syndrome, mainly diconjugates can be there, and also certain monoconjugates can be there, that is around 23%. Now we will move towards various conjugated hyperbilirubinemia. So there are mainly two inherited disorders which can give rise to conjugated hyperbilirubinemias. So one is Dubin-Johnson syndrome and another is the Rotor syndrome. So both the disease, the inheritance is autosomal recessive. In case of Dubin-Johnson syndrome, the defect is in the impaired biliary excretion of bilirubin glucuronides due to mutation in the MRP2 protein. As a result of this, there is accumulation of this dark, coarsely granular pigment in the lysosomes of centrilobular hepatocytes. And in case of Rotor syndrome, there is a possibility of decreased hepatic uptake and storage, and already there is a doubt regarding the decreased biliary excretion. So the exact pathophysiology of this Rotor syndrome is not quite clear. And essentially, there is no such specific liver pathology changes in case of Rotor syndrome. So in both these conditions, we can see that there will be hyperbilirubinemia, but that will be of the conjugated variety. Now the hepatocellular jaundice. So the second category, that is the hepatocellular jaundice, where we can see the mixed variety of hyperbilirubinemia. That means here both the unconjugated and the conjugated fraction, they can be elevated. So the various causes that can give rise to this hepatocellular jaundice is most common is the infection by various hepatitis virus. So to name hepatitis A, B, C, D and E. Except that other viruses like Epstein-Barr virus, cytomegalovirus and herpes simplex virus are the causative organisms for viral hepatitis. Alcoholic hepatitis are one of the reasons for hepatocellular jaundice. Chronic liver disease leading to cirrhosis and autoimmune hepatitis are reason for hepatocellular jaundice, and certain drugs like acetaminophen and isoniazid, they can be contributing the factor, one of the contributing factor for development of hepatocellular jaundice. Now, what is the basis of this biphasic hyperbilirubinemia? That means why both the unconjugated and the conjugated bilirubin is getting raised in viral hepatitis. So, in case of viral hepatitis, there is damage and inflammation of hepatic parenchymal cell. Due to this damage, there is impairment in the conjugation and the excretion of bilirubin is being delayed. So what happens? So due to this impairment and delay in conjugation, the unconjugated bilirubin fraction is being retained in the blood. In the second aspect, as there is inflammation of the hepatic parenchymal cells and the cells are morphologically changed or they are getting swollen up, so as a result of this, certain intrahepatic obstruction will occur. And due to this intrahepatic obstruction or this micro-obstruction, so this can cause increase in the conjugated bilirubin fraction, which will leak into the blood. And as a result of this, both the unconjugated bilirubin and the conjugated bilirubin fraction, they can be elevated. And it will give us a picture of mixed hyperbilirubinemia. So if we do the laboratory investigation of the blood sample, so what can be obtained? That both the direct and indirect fraction can be elevated, and in the LFT panel, the liver enzymes will show the characteristic pattern that there will be marked increase in the ALT and the AST. ALP, that is alkaline phosphatase, will be increased if there is micro obstruction. Now if we analyze the urine sample, so there urobilinogen can be present if urobilinogen will be decreased if micro-obstruction is present, and urine bilirubin will be present if micro-obstruction occur. And again, if this micro-obstruction is present, then the fecal stercobilinogen will be decreased. And for other conditions of this hepatocellular jaundice, in case of alcoholic hepatitis, the characteristic finding will be AST-ALT ratio, which will be at least 2:1. In case of acute viral hepatitis or toxin-related injury, we will see that the ALT level will be greater than or equal to AST, because ALT is an enzyme which is absolutely specific for liver. So for further confirmation of acute viral hepatitis, we can go for analysis of various serological profile. That means the hepatitis A IgM antibody assay, a hepatitis B surface antigen, hepatitis C viral RNA test, or hepatitis E IgM antibody assay. For autoimmune hepatitis, the autoimmune panel, that means various anti-nuclear antibody or anti-smooth muscle antibody assays can be performed. Next is predominantly conjugated hyperbilirubinemia. So predominantly conjugated hyperbilirubinemia, it is mostly caused due to various reasons of cholestasis. So cholestasis is caused by impaired bile formation and bile flow that give rise to accumulation of bile pigment in the hepatic parenchyma. Cholestasis can be either of extrahepatic or intrahepatic variety. So most common cause of cholestasis is, in case of adult, that is the gallstone, and these gallstones which can be dislodged and they can cross the obstruction of the common bile duct. Except that there are other causes like the malignancies of the biliary tree or in the head of pancreas, or the formation of strictures following further previous surgical procedures, they can give rise to obstructive jaundice. The reason behind obstructive condition in children include biliary atresia, cystic fibrosis, and choledochal cyst. Now let us focus towards the pathophysiology of obstructive jaundice. So here bilirubin diglucuronide that have been formed after the conjugation reaction, that cannot be excreted. So it regurgitates into the hepatic veins and lymphatics. So during this regurgitation, this conjugated bilirubin is coming to blood, and this conjugated bilirubin appears in the blood and urine, and the condition is called as choleric jaundice. And here the stool will be typically clay colored. And as a result of this, there will be elevation in the serum alkaline phosphatase level and gamma glutamyl transpeptidase enzyme, which are typically present on the apical canalicular membranes of hepatocytes and bile duct epithelial cells. So what are the various pathological changes contributed by obstructive jaundice? In case of obstructive jaundice, the intestinal barrier function is damaged, and here the gut permeability is increased. So it causes escape of the intestinal pathogens and endotoxin to invade the mesenteric lymph nodes and portal vein circulation and the liver. Meanwhile, the accumulation of intrahepatic bile acids, it can significantly inhibit the clearance of Kupffer cells from the resident macrophage, causing endotoxin spilling into the systemic circulation from the portal vein. And in an association to that, there is sustained release of pro-inflammatory cytokines, which can further contribute for formation of gut-derived sepsis and multi-organ failure. So the exact mechanism of this endotoxemia, inflammatory cell infiltration, and this microvascular perfusion failure were involved in the pathogenesis of this obstructive jaundice-induced liver injury. So here, this absence of bile is one of the important factor which is contributing towards this intestinal atrophy, bacterial overgrowth, and increased intraluminal endotoxin accumulation, and which is further coming to the liver, and it is being further going into the systemic circulation, giving rise to systemic endotoxemia. Now the various laboratory investigations for posthepatic jaundice. So the total bilirubin will be increased, and here the direct bilirubin fraction will be disproportionately increased in comparison to the indirect fraction. And here the serum ALP will be much higher in comparison to the ALT or AST. The Ehrlich's test for urine urobilinogen will be negative, and the bile salt and the bilirubin, as they will be coming to the urine, so the Hase sulfur test for bile salt will be positive, and if we do the Foch's test for the bilirubin in the urine sample, it will become positive. And due to the obstruction, as the bile is not being able to reach the gut, so the stercobilinogen will be either trace or it will be absent in the feces. So to summarize here, we can see that the three categories of jaundice, that is prehepatic, hepatic, and posthepatic jaundice is there. And the major cause behind this prehepatic jaundice is various hemolytic causes. In case of hepatic, there can be infective variety where there is decrease in the conjugation, decrease enterohepatic circulation, and in case of post-hepatic or obstructive variety, there is obstruction leading to regurgitation jaundice, and mostly the conjugated bilirubin fraction will be elevated. Now a brief recapitulation so that we can differentiate between the major categories of jaundice, that is this pre-hepatic, hepatic, and obstructive or post-hepatic jaundice. So if we just compare the LFT panel, so here we can see that in case of hemolytic jaundice or one of the variety of this unconjugated hyperbilirubinemia is this Gilbert syndrome. Here we will see that the bilirubin level in Gilbert syndrome does not crosses more than 5 milligram per deciliter, and here the total fraction will be mostly or around 85% will be contributed by the unconjugated bilirubin or the indirect fraction, and here no bilirubinemia will be present. In case of the liver enzymes, the LFT panel, the aminotransferases and the alkaline phosphatase level will be normal. In acute hepatocellular necrosis, that can be induced by either viral infection or ischemia or toxin-induced hepatitis, we can see a mixed picture, that is the conjugated and the unconjugated fraction both can be elevated. The elevation of the bilirubin level, this peak usually follows after the aminotransferases, and here bilirubinuria can be seen. In case of this hepatocellular variety, ALT and AST both level can be elevated, and often they can go more than 500 international units per liter. And as ALT is much more specific for liver, so ALT level will be much higher in comparison to AST. Alkaline phosphatase level can either remain normal or it can increase if it is preceded by any micro-obstruction, but the level will not cross at least the 3 times the upper reference interval for alkaline phosphatase. In chronic hepatocellular disorder, again a mixed picture can be seen. That means both conjugated and the unconjugated variety of bilirubin will be elevated. Here also aminotransferases will be increased, but the level essentially does not cross 300 international units per liter. And alkaline phosphatase can be increased, but still it will be less than the 3 times the normal upper reference interval. Another important parameter that we can see in case of chronic hepatocellular disease is the albumin fraction, which will be decreased in this chronic hepatocellular disorder, but essentially it will not be much more altered in case of acute hepatocellular diseases. In case of alcoholic hepatitis and cirrhosis, here also both the fractions may be elevated, but in case of aminotransferase, we can see a characteristic pattern that the AST and the ALT ratio, the AST fraction will be much more, that is, it should be at least greater than 2 to confirm the diagnosis of alcoholic hepatitis or cirrhosis. And the alkaline phosphatase level will be still less than 3 times the upper reference interval. And in case of post-hepatic or obstructive jaundice, both the fractions may be elevated, but mostly here we will see elevation of the conjugated bilirubin. The aminotransferases either can remain normal or there can be a moderate elevation, but it will cross rarely more than 500 IU per liter. But in case of this obstructive jaundice, we can see a much higher level of this alkaline phosphatase. And this alkaline phosphatase will be elevated, and often it will be more than 4 times the upper reference interval limit for alkaline phosphatase. Now with all this information, if we proceed towards diagnosing a case of jaundice, so what should be our approach? So at first we should do a thorough history taking of the patient, and we will do the physical examination. Next, the lab tests which are mostly important in this perspective is the liver function test, where the bilirubin fractionation, ALT, AST and alkaline phosphatase estimation, albumin and prothrombin time should be measured. So after the estimation, if we see that there is isolated elevation of bilirubin, so then we have to see the type of hyperbilirubinemia, that is whether it is indirect hyperbilirubinemia or it is direct hyperbilirubinemia. So indirect hyperbilirubinemia will be the situation where the direct fraction is less than 15% of total bilirubin. So the causes which can be causing this indirect hyperbilirubinemia are the inherited disorders like Gilbert syndrome or Crigler-Najjar syndrome. There can be various hemolytic disorders or ineffective erythropoiesis. So the direct hyperbilirubinemia, where the direct fraction is more than 15% of the total bilirubin. So various inherited disorders can be there, that are the Dubin-Johnson syndrome and Rotus syndrome. So in this situation, mostly the bilirubin level is elevated, but the other LFT enzymes are essentially normal. But if during our workup we see that the LFT panel is also deranged, that means the bilirubin is elevated along with it the other liver enzymes, they are also elevated. So then we will see the pattern. So if we see the pattern that the ALT-AST elevation is out of proportion to alkaline phosphatase, then we should think about the hepatocellular pattern, and accordingly we should evaluate for various causes of hepatocellular jaundice, like either there can be various types of hepatitis, so we can go for serology of the hepatitis viruses, or there can be various autoimmune causes, so we can go for analysis of the ANA profile, or we can go for either smooth muscle antibody estimation. But if we observe a cholestatic pattern, that means here the alkaline phosphatase is out of proportion to the ALT or AST level. So here we can be sure that it can be a cholestatic pattern. So then we have to think about various causes of cholestasis, that is either it can be extrahepatic cholestasis or it can be intrahepatic cholestasis. So if there is extrahepatic cholestasis, then we can further proceed for confirmation of the exact cause with help of various radiological procedure like CT scan, MRCP or ERCP. And if intrahepatic cholestasis is suspected, so then we can again go for serologic profile, or we can go for MRCP, and ultimately if nothing is conclusive, then we can proceed for liver biopsy. So with all this information, I hope the pathophysiology of jaundice is being explained and the learner will be able to explain the same. So thank you for your patient hearing.